If a patient walks into a clinic and, you feel this swollen, firm lump right above their left collarbone, your first thought really shouldn't be that they're fighting off some minor cold.
Oh, absolutely not. That is a massive red flag.
Right. That specific swollen node is basically flashing this bright red warning light on your diagnostic dashboard.
Wow.
It's telling you that something might be deeply wrong in their abdomen, like possibly even a gastric malignancy.
Yeah, it's honestly a phenomenal example of how the body's physical architecture gives away its internal secrets.
Mhm.
And, well, we are talking about immunology today, which is
The dreaded alphabet soup.
exactly. It is so easy for learners to just get completely lost in the microscopic alphabet soup of cytokines and cell markers and all of that.
Yeah, I mean, you look at a stack of high-yield exam notes, and it just seems like random strings of letters and numbers that you have to memorize by brute force. But our mission for you today is to break that cycle. We're diving into the hidden mechanical logic of the immune system. Because once you actually see how the machinery physically fits together, you don't have to memorize it. You just intuitively know how it works.
And on high-stakes exams, intuition built on that logic is your ultimate safety net. It's what saves you when you panic.
Totally. Okay, let's unpack this.
So if we connect this to the bigger picture, it makes sense to start with the terrain itself. Before we look at the individual cellular soldiers fighting the infection, we really need to understand the battlefield's physical supply lines.
We're talking about the lymphatic plumbing, basically.
Right, the plumbing.
It's essentially a network of regional police stations. So if a specific station is overwhelmed, you know exactly which neighborhood in the city is having a crisis. But how can we use this plumbing system to predict the exact origin of a pathology on an exam?
Well, because the drainage pathways are highly stereotyped. Palpable lymph nodes are a physical roadmap. Let's take the deep cervical nodes, for example. They drain the head and the neck. So if those are enlarged, you are logically looking for upper respiratory issues, infectious mononucleosis, or Kawasaki disease.
That makes intuitive geographic sense. The neck drains the head. But let's go back to that left collarbone warning light I mentioned in the beginning, the supraclavicular nodes.
Ah, yes.
Why is there such a massive difference between the left and right sides here?
This is a classic area where exam writers test if you actually understand the underlying anatomy, not just surface-level facts.
Right.
The right supraclavicular node drains the right hemithorax, basically just the right side of the chest. But the left supraclavicular node,
Famously known as the Virchow node, right?
exactly, the Virchow node, that is the terminus for the thoracic duct.
And the thoracic duct is like the main highway for the entire lower half of the body?
Precisely. It drains everything below the diaphragm, plus the left thorax and left upper limb, and it empties right at the junction of the left subclavian and internal jugular veins. So if a malignancy develops in the stomach or the pelvis, those cancerous cells can travel all the way up that massive thoracic highway and lodge right in that left supraclavicular node.
It's just incredible. You're feeling a node in the neck area to diagnose a stomach issue. And what if that major thoracic duct gets ruptured, say, from trauma?
You end up with a chylothorax. Lymph fluid literally leaks into the chest cavity.
Yikes. See, that's pure logical plumbing. Speaking of plumbing traps, looking at these notes, there is a very specific asymmetry in the feet that exam writers seem to obsess over.
Oh, yeah. The medial versus lateral foot drainage. It is a subtle distinction, but highly testable.
Break it down for us.
So if a patient develops cellulitis on the medial side of their foot, that lymph fluid drains straight up the leg to the superficial inguinal nodes in the groin.
Okay, straight to the groin. Wait, but if the cellulitis is on the lateral side of the foot,
It doesn't make it all the way to the groin immediately. It stops first at the popliteal nodes right behind the knee.
oh, okay, the notes actually have a shortcut for this. Poplateral. Lateral foot cellulitis goes to the popliteal node. Medial goes to the inguinal. That is a perfect exam track.
It really is.
Yeah.
Because if they give you a clinical vignette of a patient with an infected lateral toe and ask which node is enlarged, inguinal will absolutely be an answer choice to tempt you, knowing that poplateral pathway saves you.
So we've mapped out how the regional plumbing directs local traffic. But what happens if an infection breaches those local police stations?
Then things get serious.
Right, if a pathogen gets into the main blood supply, we have to travel down to the central processing facility of the immune system, which is the spleen.
The spleen is a fascinating dual-purpose organ. It contains the red pulp, which filters aging or damaged red blood cells, and the white pulp, which acts as this massive staging ground for your T cells and B cells to monitor the blood for antigens.
Here's where I want to push back a bit because this always confused me.
Sure.
We know the spleen is a giant blood filter. But if a patient loses their spleen, maybe an emergency splenectomy after a car crash, or an autosplenectomy from sickle cell disease, the notes say they are specifically highly vulnerable to encapsulated bacteria.
Correct.
But why just encapsulated ones? I mean, why wouldn't losing a massive filter make you equally vulnerable to all bacteria?
That is the crucial question, and it's where we move from anatomy to biochemistry. It isn't just about a physical filter going missing. It's about a specific chemical cascade getting interrupted.
Okay, I'm following.
The spleen houses a unique population of marginal zone B cells. When splenic function drops, you lose a massive amount of your body's ability to produce IgM antibodies against bloodborne targets.
Okay, so splenectomy basically equals a sharp drop in IgM.
Correct. Now, recall how the complement cascade works. IgM is an incredibly potent activator of the classical complement pathway. So decreased IgM directly results in decreased complement activation.
And the ultimate goal of that complement activation is to produce C3b, right?
Exactly. C3b is an opsonin. Its primary job is to coat the surface of a pathogen so that phagocytes, like your macrophages, actually have something to grab onto.
I picture C3b like molecular Velcro or an eat me sign pasted on the bacteria.
That's a great analogy. The Velcro is perfect. Now, here is why this specifically matters for encapsulated organisms.
Right, the pneumococci and those guys.
Yes. These specific bacteria, like pneumococci, meningococci, and Haemophilus influenza type B, they have incredibly thick, slippery polysaccharide capsules.
So if C3b is the Velcro, the bacterial capsule is like a thick coat of Teflon.
Precisely. A normal macrophage trying to grab an encapsulated bacteria will just slip right off. The macrophage fundamentally relies on that C3b Velcro to get a grip and engulf the bug.
Here's where it gets really interesting. I see the domino effect now. You lose the spleen.
Yep.
That means you lose the marginal zone B cells. That drops your IgM production, which stalls the classical complement pathway, which means no C3b Velcro. And without the Velcro, those Teflon-coated encapsulated bacteria just slide right past the macrophages and multiply out of control in the blood.
Leading to overwhelming post-splenectomy infection, which can be rapidly fatal.
Wow.
This is the exact mechanism behind why we aggressively vaccinate splenic patients against those specific bugs, pneumococcus, meningococcus, and Hib. You have to give their immune system pre-made IgG antibodies to compensate for the missing IgM machinery.
That is brilliant. It completely removes the need to blindly memorize a list of bugs. You just follow the biochemical cascade.
Exactly.
But what about the other side of the spleen? The red pulp. The notes emphasize that if we look at a patient's blood smear, there are massive clues that the spleen is missing.
Yes, the hematologic signs of asplenia. The most high-yield finding is the presence of Howell-Jolly bodies.
What exactly are those physically? I know they're nuclear remnants, but why are they suddenly showing up in the blood?
To understand that, you have to picture the harsh environment of a healthy spleen's red pulp. As red blood cells try to squeeze through the tight splenic cords, resident macrophages act as a rigorous quality control team. If a red blood cell has a tiny inclusion, like a leftover piece of DNA, a nuclear remnant, the macrophage will physically bite that piece out of the cell membrane, letting the repaired red blood cell continue into circulation.
So without the spleen, there's no quality control checkpoint. The red blood cells just circulate with these little chunks of leftover DNA inside them.
Exactly. And on a right gene stain, those DNA chunks show up as dark purple dots inside the red blood cell. Those are your Howell-Jolly bodies.
You'll also see target cells on the smear, right? And the notes mention an increase in platelets, thrombocytosis.
Yes. The spleen normally sequesters, or stores, about a third of your body's platelets. When you remove the spleen, all those platelets are forced into systemic circulation. It's a simple shift in volume distribution.
Okay, we've covered the regional plumbing, and we've covered the central filtering and tagging system. But tagging a bug with C3b and eating it isn't enough.
Not at all.
That macrophage has to somehow communicate to the rest of the immune system what it just destroyed so the body can build long-term immunity.
Which brings us down to the microscopic level. We are transitioning from organ-level defense to cellular communication. And this relies entirely on the major histocompatibility complexes, or MHCs.
I love visualizing MHCs as molecular serving platters.
It's a very accurate way to look at it.
A cell essentially takes a fragment of a protein it found puts it on an MHC platter, and shoves it onto its outer membrane for the passing T cells to inspect. It's either saying, hey, look at this weird virus I found inside me, or look at this bacteria I just ate from the outside.
What's fascinating here is how strictly segregated this presentation system is. The immune system cannot afford to mix up an internal viral infection with an external bacterial infection. So we have two distinct platters, MHC class I and MHC class II.
And the T cells that read these platters are also divided into two camps. CD8 positive cytotoxic T cells and CD4 positive helper T cells.
Right. And for learners preparing for exams, keeping these straight is notoriously tricky. But the source material provides a flawless mathematical shortcut to remember which key cell binds to which MHC class.
Let's hear it.
It is called the rule of 8. The product of the CD number and the MHC class number must always equal 8.
Oh, wait, let me do the math. So CD8 T cells, 8 times 1 is 8. So CD8 cells only bind to MHC class I.
Exactly. And CD4 T cells.
4 times 2 is 8. So CD4 cells only bind to MHC class 2.
Yes.
That is incredibly elegant. You literally can't mix it up.
It's a lifesaver under exam pressure.
Yeah.
Now, we need to understand the structural and functional differences between these two platters. Let's start with MHCI.
I think of MHCI as the inside reporter.
A perfect designation. MHCI presents endogenous antigens. These are proteins synthesized inside the cell itself. If a cell is healthy, it presents normal self-proteins. If a cell is infected by a virus, the virus hijacks the cell's machinery to make viral proteins.
And the cell chops up those viral proteins and puts them on the MHCI platter.
Right. Because of this vital role, MHCI is expressed on the surface of all nucleated cells in the body. Every single cell needs the ability to signal to a CD8 cytotoxic T cell, I've been compromised from the inside, please destroy me.
That makes sense. But how does the protein fragment actually get onto the platter? The notes mention a specific transporter.
The TAP transporter associated with antigen processing.
Right.
This is critical. The viral proteins are chopped up in the cytosol, but the MHCI platter is being manufactured inside the rough endoplasmic reticulum. The TAP protein actively pumps those peptide fragments from the cytosol into the ER so they can be loaded onto the MHCI molecule.
So wait, what happens if there is a genetic mutation and a patient doesn't have a functional TAP transporter?
If TPI fails, peptides cannot enter the ER. The MHCI molecule never gets loaded, and here is the mechanical rule. An empty MHC platter is unstable. It will not be transported to the cell surface.
No TAP means no MHCI on the cell surface. And if we remember the rule of 8, 0.8 times 1 is 8. If there is no MHCI, the CD8 T cells have nothing to interact with.
Exactly. They can't develop properly in the thymus, and they can't function in the periphery. This specific defect causes bare lymphocyte syndrome type I.
Oh, wow.
These patients have dangerously low levels of CD8 positive T cells and suffer from severe recurrent viral infections because their cells can't signal when they've been hijacked.
It's just a broken loading dock. Amazing.
Yeah.
Okay, let's contrast that with MHC2, the outside reporter.
While MHCI is everywhere, MHC2 is highly restricted. It is only expressed on specialized antigen-presenting cells, APCs. We are primarily talking about dendritic cells, macrophages, and B cells.
The professional eaters.
Exactly. They phagocytose exogenous antigens from outside the cell, a floating bacteria, for instance. They ingest it, trap it in a lysosome, and chop it up.
But if the cell is also making MHC cyto platters in its endoplasmic reticulum, how does it prevent its own internal proteins from accidentally loading onto MHC ticks before the bacterial fragments can get there?
That is where the invariant chain comes in. As the MHC2 molecule is being synthesized, a protein called the invariant chain acts as a placeholder. It physically plugs the binding groove of the MHC2 platter.
Oh, so it's like a reserve sign on a restaurant table. It blocks anything from sitting there.
Precisely. The MHC2 caldo molecule, with its invariant chain plug, travels in a vesicle until it fuses with the lysosome containing the chopped up bacteria. In that acidic environment, the invariant chain is degraded, the groove opens up, and the exogenous bacterial peptide is loaded.
And then it goes to the surface to present to CD4 T cells, because 4 times 2 is 8.
Correct. And just like with MHCI, if there are genetic defects, specifically mutations in the transcription factors that regulate MHC2 expression, you get bare lymphocyte syndrome type 2.
But this would be much worse, right? Because if you have no MHC2, your CD4 helper T cells can't get activated. And CD4 cells are the generals of the entire immune army.
Exactly. It cripples both the cellular and humoral immune responses, presenting clinically as a severe combined immunodeficiency, or SCID.
Okay, so we have a deep understanding of these serving platters and how they work. But this brings up a crucial vulnerability. These platters are built using genetic blueprints called HLA genes.
Yes.
And if you inherit a slightly faulty blueprint, the platter might accidentally present a normal piece of your own body to the immune system.
Which plunges us into the world of HLA associations and autoimmune disease. This is often the most frustrating part of immunology for learners because it feels like memorizing a random genetic lottery. HLA B27, DR4, DQ2.
It really is an alphabet soup. So what does this actually mean? How does a specific string of letters and numbers cause an autoimmune disease?
It comes down to the physical shape of the binding groove on that MHC platter. If you inherit the HLA B27 gene, for example, your MHC class I platters have a very specific microscopic geometry. Sometimes, that specific geometry happens to perfectly bind both a foreign bacterial peptide and a harmless peptide from your own joint tissue.
Molecular mimicry.
Exactly. The immune system attacks the bacteria, but because your HLA B27 platter also fits your own tissue so perfectly, the CD8 T cells get confused and start attacking your spine and joints.
That makes the pathology so much clearer. It's an accidental geometric fit. So, looking at the notes, what are the high-yield shortcuts you absolutely need to lock in for the exam? Let's start with that B27 blueprint.
The classic mnemonic for HLA B27 is PAIR, P-A-I-R. It stands for the seronegative spondyloarthropathies, psoriatic arthritis, ankylosing spondylitis, IBD-associated arthritis, and reactive arthritis.
PR goes with B27. Got it. What about rheumatoid arthritis?
Rheumatoid arthritis is heavily associated with HLA-DR4. The mnemonic here is phonetic. There are 4 walls in one room. Room sounds like room. 4 walls in one room.
Okay, that is beautifully cheesy. 4 walls in one room for DR4 and rheumatoid arthritis. I'll take it. Let's do type 1 diabetes mellitus.
Type 1 diabetes has a few key associations. The primary ones are DR3 and DR4, and the math trick here is incredibly simple. 1 plus 3 equals 4.
Type 1 is associated with 3 and 4. 1 plus 3 is 4. Perfect. But the notes also say it's associated with DQ2 and DQ8.
Yes, and those DQ2 and DQ8 genes are highly testable because they are heavily associated with another major condition, celiac disease. If you see a patient with celiac disease, they are very likely carrying DQ2 or DQ8.
So what does this all mean for the patient or for you reading a clinical vignette? If a patient has the HLA-DR4 gene, are they 100% destined to get rheumatoid arthritis?
No, and that is a vital distinction. These are not deterministic mutations like we see in cystic fibrosis. They are susceptibility genes. Having the blueprint fundamentally shifts your risk profile, altering the mathematical odds that a molecular mimicry event will trigger an autoimmune cascade.
Right, it's about probability, not certainty.
And that probability is exactly how exam questions will frame it. They aren't going to hand you a B27 lab result and ask for the disease. They will describe a 25-year-old male with lower back pain and morning stiffness that paradoxically improves with exercise.
Which is the classic presentation of ankylosing spondylitis.
Right. And then the question will ask, which of the following HLA subtypes is most likely present in this patient? You have to diagnose the clinical picture first, remember the paramnemonic, and link it back to B27.
You have to understand the whole interconnected web, and honestly, that is the biggest takeaway from this entire deep dive. When you trace the physical reality of the immune system, from the palpable Virchow node warning you of a stomach tumor, down to the marginal zone B cells in the spleen failing to make IgM against encapsulated bacteria,
down to the TAV transporter failing to load the MHC-I platter, all the way to the percent shape of the HLA B27 binding groove.
it stops being a phone book of random facts. You can trace the exact chain of causality. You break the TP transporter, you intuitively know CD8 cells will crash. You lose the spleen, you intuitively know you need the pneumococcal vaccine. It is pure structural logic.
It transforms rote memorization into applied problem solving.
But before we wrap up, I want to leave you with one final provocative thought from the source material that genuinely blew my mind. It's about a protein in the thymus called ERR.
Ah, the autoimmune regulator protein. It is arguably the most important safety switch in the entire body.
The notes mention that as your T cells are maturing in the thymus, they have to undergo negative selection. Basically, the thymus has to test every single new T cell to ensure it won't accidentally attack your own organs. And the mnemonic here is, without air, your body will chasseur, referring to the massive autoimmune destruction that occurs if this gene is mutated.
It leads to autoimmune polyendocrine syndrome.
Right. But if you stop and think about the physical mechanism of that test, For the thymus to ensure a T cell won't attack your liver or your retina or your heart, the thymus has to actively show that T cell a piece of liver, retina, and heart protein.
Which means the epithelial cells in the thymus are actively expressing fragments of virtually every single protein your body is capable of manufacturing.
Exactly. A developing baby's thymus, before the baby has even taken its first breath, is using the air protein to force its cells to run a massive microscopic simulation of every single tissue in the entire human body. It is running a biological holodeck simulation inside of you just to thoroughly stress test your immune system so you don't destroy yourself.
It is a stunning realization of how sophisticated and heavily regulated our cellular machinery truly is.
It really is a biological miracle. So as you head back to your studying, don't let the alphabet soup intimidate you. Take a breath, trust the logic of the machinery we've just unpacked, and go crush those exams. Thanks for joining us on this deep dive.